My name is Tuomas Rissanen and I come from Joensuu, Finland, and my topic is everyday use of drug-coated balloon in the cath lab. I would like to thank the organizers for invitation for this interesting meeting. These are my disclosures. The current indications for DCB in coronary arteries include in-stent restenosis and in de novo lesions of small vessels as shown by basket small 2 trial 2 years ago, and also the bleeding risk patients benefit from use of DCB as shown our randomized debut trial published 2 years ago in the Lancet journal. The potential indications include de novo lesions in diffuse disease, bifurcations, especially the sidebranches, following rotablation, as well as Stemi patients and the distal disease in CTO-PCI. In this presentation, I will concentrate on the DCB-only strategy in de novo lesions. The concept of conditional stenting is not a new idea. This is a paper from New England Journal of Medicine 25 years ago, where Dr. Biddle proposed that if a stent-like result is achieved after predilatation of the vessel, the lesion can be left without further stenting. However, nowadays most interventional cardiologists think that PCI equals to stenting. Personally, I think that this is not right. Stenting everything leads to suboptimal clinical results. There are still significant problems related to DES. Stenting always requires at least 1 month DABT, which may be problematic in patients with high bleeding risk. Then there is always a risk of stent thrombosis. Stenting may compromise sidebranches. Two-stent techniques are complicated and they are time-consuming. And one has to remember that metallic stent is a permanent implant, and we don't really know the results of the modern DES up to 5 to 10 years. The benefits of DCB instead of DES are very short DABT, even single antiplatelet therapy in patients with very high bleeding risk, and in case of bleeding all antithrombotics can be stopped, which is not possible after 4 weeks of DS implantation. The low target lesion revascularization rate, very low risk for acute occlusion in registry trials and also in RCTs, and the possibility for positive remodeling of the treated vessels. In order to have optimal results with the DCB-only strategy, the lesion must be prepared with 1:1 balloon-to-vessel ratio, either with NC, SC or cutting balloons, and calcium must be debulked with rotablation, lithotripsy, and in some cases intravascular imaging may be used. If there is a flow-limiting dissection or recoil over 30%, DES is recommended. In all other scenarios, DCB may be used. This figure illustrates the DCB-only concept leading to positive remodeling of the treated vessel. Immediately after PCI with DCB, there is always a little bit dissections and a result looks suboptimal. However, after a few months, there is a positive remodeling by increased shear stress and wall strain in the vessel, and a paper published a few years ago showed that this may lead to 10% enlargement of the treated vessel. However, after stenting, you always gauge the vessel and no positive remodeling may occur. This is a good example of positive enlargement of the paclitaxel DCB only PCI in a very diffusely diseased circumflex artery, which showed quite a massive enlargement 6 months after DCP-only PCI. Because of the meta-analysis of Katsanos, there is a question if paclitaxel DCP is safe in coronary arteries. Recently, a patient-level meta-analysis of paclitaxel-coated balloons in coronary arteries was published by Dr. Bruno Seller and the research group. In this paper, there was 4,500 patients and 26 RCTs, and it showed that there is no concern of paclitaxel DCPs in terms of increased mortality. On the contrary, the use of paclitaxel DCPs was associated with decreased mortality in comparison to the other treatment modalities. Is PCI using the DCP-only strategy effective in different clinical scenarios? First, we take a look at the diffuse disease. This is an angio of a male of his 50s showing a very diffusely diseased LAD and a proximal lesion as well. The whole LAD was predilated with NC balloons from the apex to the proximal part, and the proximal part showed recoil of over 30%. However, the flow was Stemi 3. A hybrid DS DCP approach was used here, meaning that the proximal part of the LAD having recoil was tended with DS, but the whole B and C parts having the diffuse disease were treated by paclitaxel-coated DCPs. The final result was good. The flow was Stemi 3. There was some dissections of A and B types without any ECG changes or chest pain, and this hybrid approach prevented from a full metal jacket in the vessel, which usually leads to the compromise of the side branches in the LAD. The next clinical scenario is bifurcations. Here you can see Medina 101 class LAD stenosis involving also ostial diagonal stenosis. The tightest stenosis in the LAD was predilated with the cutting balloon and then the side branch with NC balloon. After this, the more distal, less diseased part of LAD was measured with FFR, showing deep ischemia, and therefore this part was also treated with DS after predilatation of the segment. Because of no significant recoil in the side branch, DCB was applied there first in order to not to tear off the drug when passing through the struts of the main vessel stent, and the other reason is that it's much easier to put the DCP in the side branch before implanting the main branch stent. Post-dilatation was done in a normal fashion, and then OCT imaging showed good apposition of the stent as well as the patency of the diagonal side branch. Next, DCP in calcified lesions. 4 years ago, we were the first ones to show that DCP is feasible and effective after rotablation, resulting in low MACE and TLR rates. This is a very sick patient having a suboptimal occlusion in the circ and then CTO in the LADB and then the culprit in diagonal branch. The plan was to treat the diagonal branch first and then later open the LAD if there were symptoms. Because the patient was anticoagulated and had anemia, only aspirin was given together with heparin and then cangrelor infusion during PCI. Because of the calcified target vessel, upstream rotablation was used with 1.5 mm burr. After rota, NC balloon was applied, but it was undilatable, and thereafter a cutting balloon was also tried, but it didn't work either. Thereafter we took the shockwave catheter and applied 10 pulses, which totally opened the lesion very nicely. Because of the severe bleeding risk, including anticoagulation and anemia, and because a later CTO PCI procedure was possibly planned, DCP was applied in this calcified lesion. Here you can see the final result with no recoil or significant dissection of the treated part. We didn't give any ADP blocker to this patient, only anticoagulation together with 1 month after PCI. A perfusion scan was done to evaluate ischemia in the LAD territory. Perfusion scan showed that there is a scar with some border shown ischemia, and because the patient was asymptomatic, we didn't open the occluded LAD. We performed control angiogram 12 months after PCI, which showed great long-term result with no restenosis in this complicated calcified lesion. How about DCP-only strategy in CTO? The data on CTOs and DCP-only strategy is scarce, but there are some evidence. This paper, published a few years ago, showed that if the final result is good after DCP-only approach, almost all the vessels treated are patent in control angio 3 to 6 months later. However, the successful long-term result requires lumen-to-lumen wiring as well as normal flow after the procedure. This is a LADB CTO in a patient with anticoagulation. First, antegrade wire escalation was successful in this patient, followed by predilatation using trio NC balloons and trio cutting balloons. This is the result after predilatation with normal TIMI-3 flow and no significant recoil of the treated segment. Thereafter, 2 long paclitaxel-coated DCPs were applied to cover the whole diffusely diseased segment of the vessel. The final result was acceptable with no significant recoil in the occluded part and TIMI-3 or at least 2.5 blood flow. Interestingly, we did control angio 4 months later, showing again enlargement of the treated vessel and especially the distality of LAD. This is another example of LAD occlusion. There is an old stent from left main to LAD, and after that there is a total occlusion. Luckily, there were septal collaterals which were usable for surfing, and a retrograde approach was feasible after failure of antegrade wire escalation. After wiring the lesion from the retrograde, normal reverse guard was done, and predilatations to the distality of LAD and to the occluded proximal part was performed. The occluded segment of the LAD was stented, and thereafter antegrade injection of contrast showed very diffusely diseased LAD with no good landing zones for stenting. That's why 2 long DCBs were applied for 1 minute dilatations in the diseased part of the LAD. Here is the final result with all the side branches of the LAD patent, and there is a possibility for the vessel to grow in the follow-up because the stent is limited only to the total occlusion part of the vessel. Finally, I'd like to share a Stemi case with you. This is a male patient at his 60s presenting with anterior Stemi infarction, and immediate coronary angiogram showed LADB Medina 010 occlusion. Importantly, this was a bifurcation for 4 vessels, and this patient had aspirin allergy. After wiring, some flow was established in the LAD, and lots of thrombus was visible, which was aspirated with a catheter. After thrombus aspiration, predilatation was done with 3.5 NC balloon. Because a stent-like result was achieved by this predilatation, we decided to finalize the treatment of the vessel with paclitaxel-coated DCB. The final result was very good, without any recoil, normal blood flow, and no compromise of the side branches. In this patient with aspirin allergy, it's beneficial not to have a permanent metallic implant in the bifurcation lesion. I'd like to thank you for your attention, and it was my honor to share some clinical cases and experience on DCB-only strategy. I hope that these were helpful for you, and I wish all the best. I think we all need to look on the horizon and hope for the better future. Thank you.